Bismillahirrahmanirrahim. Today we are going to start the step 2 Uworld notes audio version, and now let's get straight into that. We are starting GIT firstly. So the very first topic we are going to talk about is dysphagia. So how do we evaluate dysphagia? These are the Uworld notes. So this logarithm states that history of difficult initiating swallowing with cough, choking, or nasal regurgitation. If that is present, likely it is oropharyngeal dysphagia, and if it is not present, it is esophageal dysphagia. If it is oropharyngeal dysphagia, we will do the video fluoroscopic modified barium swallow if the symptoms suggest neuromuscular disorder, or if symptoms suggest mass lesion causing mechanical obstruction, we will see nasopharyngeal laryngoscopy. But if there is esophageal dysphagia, so we will see if it is dysphagia for solid progressing to liquids or dysphagia with solid and liquids at the onset. If it is dysphagia with solids progressing to liquids, then it most likely is the mechanical obstruction. We will check for the history of prior radiation, caustic injury, complex stricture or surgery for the esophageal cancer. If these are present, we will perform the barium swallow followed by possible endoscopy. If this is not present, then we perform the upper endoscopy. Now, if it is dysphagia with solids and liquids at the onset, it is going to be a motility disorder, and for that we perform the barium swallow followed by possible manometry. What is oropharyngeal dysphagia? It is the inability to properly transfer food from mouth to pharynx. Food is stuck in the throat, not esophagus. Etiology: stroke, advanced dementia, oropharyngeal malignancy or neuromuscular disorder like myasthenia gravis. Complications: aspiration pneumonia and weight loss. Video fluoroscopic modified barium swallow studies preferred initially to evaluate swallowing, mechanics, degree of dysfunction, and severity of aspiration. Okay, any sharp object in the esophagus should be removed emergently by flexible endoscopy. Foreign bodies should not be allowed to remain in the esophagus for more than 24 hours. Sharp, pointed objects, for example fish bone, pointed pins, have a risk of esophageal perforation and should be removed urgently with endoscopy. Esophageal motility studies and upper gastrointestinal endoscopy are typically used for evaluating esophageal dysphagia, which presents with a sensation of food getting stuck in the esophagus, not throat, a few seconds after swallow, but does not cause difficulty initiating the swelling. So this is the hallmark of esophageal motility studies, uh, that in esophageal dysphagia, the food is going to stuck after a few seconds in the esophagus, not in the throat, and there is no difficulty in initiating the swallowing. The next point is about hernias. The next point is about esophageal motility disorders. So major esophageal motor dysfunctions are achalasia and hiatal hernias. So you must be able to differentiate between the achalasia and hiatal hernia. Achalasia is a condition in which the lower esophageal sphincter is not going to relax properly, and there is an increased lower esophageal sphincter tone. As you can see, the lower esophageal sphincter is present over here, just above the cardia, and that is so much contracted that food cannot pass this point, and there is a bird beak appearance to that. We will talk about that later on. But this is the picture of achalasia, and this is hiatal hernia. Now, hiatal hernia, this is the diaphragmatic hiatus for esophagus. It is also called as esophageal hiatus. So, if the fundus of the stomach is herniating directly above through the hiatus, and the gastroesophageal junction is moving upward, that is called as sliding hiatal hernia. But if the gastroesophageal junction is in its place and fundus is herniating parallel to the esophagus, that is called as rolling uh, or paraesophageal hiatal hernia. The next point is about Zenkus diverticulum. So here you can see the Zenkus diverticulum is an outpouching. It is a diverticulum that is present in the esophagus. You must remember that it is a false diverticulum, which means that all three layers of mucosa, submucosa, and muscularis are not herniating outwards. Muscularis propria, and this diverticulum is present at the level of Killian's triangle. Then there is another diverticulum that is called as epiphrenic diverticulum, and that is present over here. I guess it is also a false diverticulum. Now let's talk about them one by one. Achalasia and pseudoachalasia both present with dysphagia to solids and liquids with smooth tapering of the lower esophagus. Achalasia, I will talk about these points later on. So achalasia, loss of peristalsis in the distal esophagus with lack of esophageal sphincter relaxation, lower esophageal sphincter relaxation. symptoms of more than 5 years before receiving the diagnosis, and mild weight loss. So symptoms must be present for more than 5 years before receiving a diagnosis, and there must be a mild weight loss. So these are the things that will clue you into the diagnosis of achalasia. Endoscopy. In achalasia, this evaluation. Yep. So in achalasia, where are we? In achalasia, the evaluation usually shows normal appearing esophageal mucosa and a dilated esophagus with possible residual material. In addition, it is generally possible to easily pass the endoscope through the lower esophageal sphincter, unlike in malignancy. It is very important point that although the lower esophageal sphincter is not relaxing properly, but you can pass the endoscope easily through that lower esophageal sphincter. It is not like that in the case of malignancy. Like if there is some obstruction, structural obstruction caused by a malignant outpouching or maybe an exophytic mass that is protruding into the esophagus, you cannot pass the endoscope beyond that. But if it is achalasia, you can definitely pass the endoscope into the stomach. The treatment is laparoscopic myotomy and pneumatic balloon dilation. Treatment of choice in the patient with a low risk of surgery. Patient with a high risk of surgery, we do botulinum toxin injection, nitrates and calcium channel blockers, but exclude the malignancy first. So myotomy means the lower esophageal sphincter muscles are being dissected and resected surgically. Pneumatic balloon dilation means, like suppose this is the lower esophageal sphincter, we insert a balloon catheter, like suppose this is the balloon. Okay, I have to zoom it in. I suppose this is the balloon catheter which was inserted over here, and then the balloon is inflated, and when the balloon is inflated, it looks something like this and like this. So balloon becomes large. So due to that inflation of the balloon, the lower esophageal sphincter that was previously constricted, that also gets somewhat opened up and relaxed, and the achalasia is treated. And this is not a very very good treatment, but it is confined for the people who have surgical limitations, who cannot undergo surgery. So we can do it like this. Okay, I'm sorry for this broken diagram, but this is how the pneumatic dilation basically works. So pseudoachalasia, what is meant by that? Pseudoachalasia is a condition. So pseudoachalasia, it is due to the esophageal cancer due to the denervation. Okay, so achalasia was basically because of lack of lower esophageal sphincter to open properly, and that was because of lack of ganglion cell present in that segment. Pseudoachalasia is due to the esophageal cancer, not due to denervation, while achalasia is due to denervation. Rapid symptom onset less than 6 months. Do you remember how much time was required for making a diagnosis of achalasia? It was more than 5 years. But for the pseudoachalasia, the symptoms are less than 6 months. There will be a significant weight loss, alcohol and tobacco history, age more than 60. You must perform the endoscopic evaluation to exclude malignancy. Later, CT and staging to exclude malignancy. Malignancy, okay, we know it is cancer. So what do we mean by excluding malignancy? It means that we must perform the endoscopic evaluation to check if the cancer has spread or not, or if the somehow we perform the endoscopic evaluation to exclude the malignancy. Later, the CT for staging, and CT can also be performed if the endoscopy is unrevealing and there is a high suspicion of malignancy. Okay, so let's read these extra points. So chronic dysphagia to both solids and liquids. So they're saying that the chronic dysphagia to both solids and liquids, regurgitation, difficulty belching, and mild weight loss are all common manifestations of achalasia. Other symptoms include chest pain and heartburn. Therefore, many patients are initially diagnosed with a gastroesophageal reflux. Being in the upright position increases the pressure in the esophagus, results in more effective swallowing. That is a very important point, that the patient will complain that when I am sitting upright in upright position, I can swallow things properly, but when I lie down, the things are hard to swallow. So being in the upright position increases the pressure in the esophagus and result in more effective swallowing. This prevents the food or liquid from passing through the lower esophageal sphincter until the hydrostatic pressure in the esophageal column is greater than the closing pressure of the sphincter. Okay, it was not linked by that. They were talking about lower esophageal sphincter relaxation. So basically, the lower esophageal sphincter what is the point of, or what is the mechanism of lower esophageal sphincter relaxation? The lower esophageal sphincter is normally in the constricted position, but when the hydrostatic pressure in the esophageal column becomes higher, then the constriction, then the closure pressure of the sphincter, then it opens up. So this was a point linked to that. Next point is about manometry. Manometry is most sensitive test and the key to diagnosis. Barium esophagogram, which may show a smooth bird beak narrowing near the lower esophageal sphincter, can be helpful in patients with a non-diagnostic manometry. So the patients who have non-diagnostic manometry, we can perform the barium esophagogram in those patients. Otherwise, the manometry is most sensitive test and the key to diagnosis of achalasia. Now let's move forward. Diffuse esophageal spasm, that is another condition. The pathophysiology of diffuse esophageal spasm is uncoordinated, simultaneous contraction of the esophageal body. Symptoms are intermittent chest pain, dysphagia for solids and liquids. Diagnosis is made with the esophagogram. There will be a corkscrew pattern. On manometry, there will be intermittent peristalsis and multiple simultaneous contractions of middle and lower esophagus. The lower esophageal sphincter usually shows normal relaxation in the case of diffuse esophageal spasm. But for the diffuse esophageal spasm, the corkscrew appearance is very important buzzword, as well as if they show you a CT scan or if they show you a barium swallow X-ray, so you must be able to diagnose and pick up the corkscrew pattern of esophageal contractility. Now the treatment is calcium channel blockers, for example diltiazem, and alternate nitrates and tricyclics. Like if the patient has some contraindication to calcium channel blockers, then we must go for nitrates and tricyclic antidepressants. So here you can see that diffuse esophageal spasm, spontaneous pain, odynophagia for cold and hot food, precipitation by the emotional stress. So basically diffuse esophageal spasm is associated with spontaneous pain. Odynophagia for cold and hot food will also be present. The precipitation of DES, the precipitation of pain in DES is caused by emotional stress. Resolution of chest pain after taking nitroglycerin. So basically this is some question stem which has been broken down. So the like these are the points from some question stem, and the points which were taken to the diagnosis of diffuse esophageal spasm are listed over here. So in diffuse esophageal spasm, there will be spontaneous pain, odynophagia for cold and hot, precipitated by emotional stress, resolved by nitroglycerin. Nitrates and calcium channel blockers relax not only the myocytes in the coronary vessels but also those in the esophagus, thereby alleviating the pain. Then esophagography may or may not show other anomalies. For example, corkscrew shape due to the non-peristaltic contraction is neither sensitive nor specific. You must remember that it although it is a very important buzzword, but it is not always present. Esophageal manometry should show repetitive, non-peristaltic, high-amplitude contractions either spontaneously or after ergonovine stimulation. Then here you can see that due to impaired inhibitory innervation of esophagus. Why is there diffuse esophageal spasm? Because of impaired inhibitory innervation of esophagus, often seen in association with the emotional factors and functional GI disorders. Functional GI disorders are they are basically psychiatric conditions. You may not call them psychiatric conditions because they are not listed in the DSM-5, but they are the GI conditions which are caused by some psychiatric factors. And when you perform the CT scan or investigations, everything is normal and functional, but the thing is that due to the emotional disturbances, the GIT is not functioning properly. Then symptoms resemble achalasia, impaired relaxation of lower esophageal sphincter, and nutcracker esophagus, which is excessive tone in the lower esophageal sphincter. Endoscopy is usually normal. Now what is dyspepsia? The causes of dyspepsia are GERD, non-steroidal anti-inflammatory drugs, gastric or esophageal cancer, functional dyspepsia, and symptomatic Helicobacter pylori infection with or without peptic ulcer. According to the ROM3 criteria, dyspepsia is defined as one or more of the following symptoms: postprandial fullness, classified as a postprandial distress and postprandial distress syndrome; early satiation, inability to finish a normal sized meal, also classified as postprandial distress syndrome; and epigastric pain or burning, that is classified as epigastric pain syndrome. So this is the definition of dyspepsia. Dyspepsia is defined as more than one of the following symptoms like postprandial fullness, epigastric pain or burning, and early satiety. Patient age more than 55 with an alarm features, for example, unintentional weight loss, persistent vomiting or hematemesis, unexplained iron deficiency anemia should undergo endoscopy. So here is an algorithm for the management of dyspepsia. So here you can see, in dyspepsia there can either be typical GERD symptoms, NSAID or COX-2 inhibitor use, or no GERD or NSAID or COX-2 inhibitor use. So now let's talk about the first point, that is typical GERD symptoms, dyspepsia with the typical GERD symptoms. How do we treat that? We do the acid suppression with a PPI or H2 receptor blocker. If we are having NSAID or COX-2 inhibitor use, if there is a history of that, so discontinue the agent or acid suppression, and that is also preventable by proton pump inhibitors. The third thing is no GERD or NSAID COX-2 use. Now if there are no alarm symptoms, so we'll check for the age. If the age is more than 55, so we perform the endoscopy. If the age is less than 55, then we do the H. pylori testing. If the H. pylori testing is positive, then we treat the H. pylori. If it is negative, then we perform the PPI trial for 4 to 6 weeks. So, and if the GERD or NSAID use is not present, but there are alarm symptoms along with dyspepsia, then we go for endoscopy. And the patients who fail to improve with treatment regardless of symptoms, we also go for endoscopy. Like we treated the patient with H. pylori, and the patient did not improve, although we were giving treatment. So we also, in those cases again, we go to endoscopy. So there is a new table in the step 2 CK management of GERD in question ID 2200. So see that again. Criteria given here in men. The criteria given here is men aged more than 50 with symptoms for more than 5 years of cancer risk or alarm symptoms. Indication of H. pylori testing. Why do we perform the H. pylori testing? If the patient is high risk for H. pylori, such as those living in the regions with high prevalence or household exposure, may elect for test and treat strategy. Breath test or stool test and stool antigen tests are done and not serology. Common methods for determining the bacterial eradications include urea breath testing and fecal antigen testing. Testing should occur more than 4 weeks after completion of therapy. Now let's talk about GERD. Evaluation and treatment of GERD. Let me zoom it in. So typical GERD symptoms. Typical GERD without alarm symptoms are dysphagia, odynophagia, weight loss, anemia, GI bleeding, recurrent vomiting. These things are alarm symptoms. So if there is a typical GERD which does not have these symptoms, we do the trial for daily PPIs, proton pump inhibitors. If the person is refractory to that, we change the proton pump inhibitor or increase the use of proton pump inhibitor twice daily. Initially we were giving once daily, but if it is the person is refractory to that, either we change the proton pump inhibitor or we increase the dose to twice daily. If it is persistent, then endoscopy or esophageal pH monitoring can be done. Typical GERD with alarm symptoms. Okay, so now there is typical GERD with alarm symptoms like dysphagia, odynophagia, weight loss, anemia, GI bleeding, and recurrent vomiting, or men who are more than 50 with chronic symptoms or cancer risk factors. Like there are chronic means more than 5 years, and cancer risk factors like there is tobacco use. We do the endoscopy before trial. Esophagitis due to autoimmune or Barrett esophagus. Treat accordingly, not esophagitis. Further evaluation, for example, manometry can also be done. Then what are the complications of GERD? First one is the Barrett esophagus, then erosive esophagitis and esophageal peptic strictures. Benign strictures. Now benign strictures affect 5 to 15% of the patients with a GERD. Other causes of esophageal strictures are radiation, systemic sclerosis, and caustic ingestions. Progressive dysphagia to solids without anorexia and weight loss leads to, so there is in strictures there will be progressive dysphagia to solids without anorexia or weight loss, and it leads to improvement in heartburn. What is that? Leads to improvement in heartburn. What's meant by that? If there is stricture formation, that will lead to improvement in heartburn. Yes, because if there is stricture formation, the reflux of acid will be inhibited, so there will be improvement in the heartburn. So both strictures and Barrett metaplasia can occur simultaneously in response to chronic exposure to the gastric acid. Moving to the next point, systemic symmetric circumferential narrowing on the barium swallow will be seen. In any case of stricture in the setting of Barrett esophagus, biopsy is necessary to rule out adenocarcinoma. This is done via endoscopy, which may be diagnostic and therapeutic. Dilation is done if the malignancy is not found. Patients with a Barrett's esophagus have 1% per year chance of developing subsequent esophageal adenocarcinoma. So, we perform the endoscopy, that is therapeutic as well, because when we do the endoscopy, we can dilate the segment which has been constricted, and when we do that, so that is a therapeutic approach. Otherwise, we do the endoscopic biopsy to rule out the adenocarcinoma, because the person who is having the Barrett's esophagus has 1% per year chance of developing subsequent adenocarcinoma. Management of the gastroesophageal reflux disease. Now, there is an algorithm, Uworld algorithm to that. So, first one is the symptoms consistent with a GERD. So, the symptoms which are consistent with a GERD are men aged more than 50, symptoms for more than 5 years, or cancer risk factors or alarm symptoms. If they are present, then we go for endoscopy. On endoscopy, we look for esophagitis. If esophagitis is present, then treat according to the diagnosis, like either it is pill esophagitis or autoimmune skin disease, Zollinger-Ellison syndrome, eosinophilic esophagitis or Barrett esophagus, treat that. If there is no esophagitis but still there is alarm symptoms or symptoms which are consistent with the GERD, then consider further testing for following diagnosis. Diagnose for achalasia, gastroparesis, non-acid reflux diseases, nocturnal acid breakthrough. And you must also do for all these conditions, you must perform esophageal manometry, impedance testing, and gastric scintigraphy. Here you can see the other side of the logarithm, that if the symptoms are not consistent with the GERD, like if the age is less than 50 and if the symptoms are not for 5 years or the cancer risk factors are not present and there are no alarm symptoms, then we do the once daily PPI for 2 months. If the symptoms are refractory, switch to a different PPI or increase the proton pump inhibitor to twice daily. If the symptoms are controlled, continue the present therapy. If the symptoms are persistent and not controlled, then consider the endoscopy or esophageal pH monitoring. What are the alarm symptoms? Alarm symptoms include melena, and that is dark stools, persistent vomiting, hematemesis, that is vomiting of bright red blood, weight loss, anemia, and dysphagia and odynophagia. So these are the alarm symptoms. The next point is about the patient with a history of chronic gastroesophageal reflux disease more than 5 years or frequent reflux symptoms like heartburn with more than equal to 2 factors, risk factors such should be considered for endoscopic screening for Barrett esophagus. Risk factors include age more than 50, male sex, Caucasian, hiatal hernia, obesity or increased waist circumference like more than 102 centimeters, current or former tobacco use, first degree relative with a Barrett esophagus or esophageal adenocarcinoma. If there is no dysplasia, proton pump inhibitor and surveillance endoscopy is done for 3 to 5 years. If there is low grade dysplasia confirmed by the pathologist, we perform the PPI and surveillance endoscopy every 6 to 12 months, or endoscopic eradication can also be done in early stages of dysplasia. If it is high grade dysplasia, which is confirmed by the pathologist, endoscopic eradication therapy is done. Even in the case of very high grade dysplasia, we can perform esophagectomy, either partial or complete. The next point is stress ulcer. Indication for stress ulcer prophylaxis: any one factor, coagulopathy, platelet less than 50,000 per millimeter cube, INR more than 1.5, PTT more than 2 times the normal control. Now you must remember that the stress means physical stress, it is not psychological. The physical stress factors like sepsis or trauma or some other serious illness. So indication for stress ulcer prophylaxis are if the person is having coagulopathy, like the platelets are less than 50,000, INR more than 1.5, and PTT, which is the PTT is for the intrinsic pathway, right? So it must be more than 2 times the normal control. So then you must start the prophylaxis. Mechanical ventilation, the person is on mechanical ventilation for more than 48 hours. GI bleeding or ulceration in last 12 months. Head trauma, spinal cord injury or major burn. More than 2 factors, glucocorticoid therapy. If the person is having glucocorticoid therapy or more than 1 week of ICU stay, occult GI bleeding for more than 6 days, and sepsis. So these people are at risk for development of stress ulcer, and we must do the prophylaxis in those patients. This mechanically ventilated patient, so there is a question in which there was a mechanically ventilated patient, so this is a discussion of that. So the mechanically ventilated patient with recent head trauma has developed an upper GI bleeding as evidenced by the melanic bowel movements and anemia. This is most likely from the gastric or esophageal stress ulcer. Critically ill patients may have uremic toxins and reflux of bile acids into the stomach. Both can disrupt the protective glycoprotein layer, which can lead to the increased permeability of the gastric mucosa, predisposing to ulcer formation. Head trauma causes increased gastrin secretion, leading to the partial secretion, leading to parietal cell stimulation and acid secretion. Why? Because whenever there is head trauma, there is excessive parasympathetic outflow, and that will parasympathetic outflow is taken by the vagus nerve, and vagus nerve can cause an increase in the acid production. So, head trauma causes increased gastrin secretion, leading to parietal cell stimulation and secretion. Shock is associated with a mucosal ischemia, leading to ulcerations. Most of these ulcers occur within first 72 hours and tend to be located in the proximal stomach. Ulcerations occurring later in hospital course tend to be located in the duodenum. Proton pump inhibitors as well as H2 antagonists are used. H2 antagonists are used to increase the pH in the stomach by lowering the gastric acid formation, which prevent PPIs and H2 antagonists both are used to increase the pH in the stomach by lowering the gastric acid formation, which prevent the gastric injury associated with ulcer formation. Proton pump inhibitors may also have increased efficacy in the acid suppression. Both proton pump inhibitors and H2 antagonists may be associated with the increased risk of Clostridium difficile infection and pneumonia. Okay, so the next point is about globus sensation, that is called as hystericus. The globus sensation, like the sensation when you feel that the food is stuck in the esophagus. The globus sensation is a functional disorder of the esophagus that is characterized by sensation of foreign body in the throat. It is often worse when swallowing saliva and is frequently associated with anxiety, pain, dysphagia, dysphonia, or systemic symptoms are not typical for the globus and suggest other conditions. What is pill esophagitis? So, esophagitis is caused by peas, pill, infection. I think the piece is a mnemonic, I'm sorry. So, it is a mnemonic, the PIECE. Okay, let me zoom it in. So, the mnemonic for esophagitis is peas, that is pill esophagitis. There can be infectious esophagitis like cytomegalovirus or herpes esophagitis. Then there is eosinophilic esophagitis, in caustic esophagitis caused by ingestion of some caustic substance, and then there is GERD. So, the peas is a mnemonic for that. Esophagitis, pill esophagitis, infectious, eosinophilic, caustic, and GERD. Good. Now let's talk about pill esophagitis. Antibiotic. So what are the medications which induce esophagitis? Are antibiotics like tetracycline due to acid effects, anti-inflammatory agents like aspirin and many non-steroidal anti-inflammatory drugs. What do? They disrupt the normal gastroesophageal protection. Bisphosphonates like alendronate and risdronate. Then others include potassium chloride and iron. So potassium chloride is causing osmotic tissue injury. So these are the drugs that are most important in causing the pill esophagitis. Symptoms: sudden onset of odynophagia and retrosternal pain that will cause difficulty swallowing, common in the mid esophagus due to its compression by aortic arch or the enlarged left atrium. Diagnosis is made clinically but can be confirmed on endoscopy. Discrete ulcers with a normal appearing surrounding mucosa will be present. The treatment is that stop offending medicine to prevent the future injury. So, if the person is allergic or the person develops esophagitis after the tetracyclines, you must switch the antibiotic to some other class. GERD is infrequent, like less than 2 times per week. More, I don't know what is that. GERD infrequent. Ranitidine, H2 receptor blocker, prone with low LSM. GERD frequent, more than 2 times per week. Okay, so if the GERD is infrequent, less than 2 times per week, we give the ranitidine or H2 receptor blocker, PRN with the LSM. What is LSM? LSM. Lower sphincter myotomy. Like if the GERD is infrequent, so I don't know what's the meaning of that. Okay, so GERD is frequent more than 2 times per week. We give the low dose proton pump inhibitors. If there is a failure, we give the high dose proton pump inhibitors. If there is failure again, then we go for manometry or endoscopic gastroduodenoscopy. But I still don't understand the meaning of LSM. Okay, and what is PRN? I don't know. The next thing is esophageal rupture. Clinical features of esophageal perforation. First, we will talk about etiology. Spontaneous rupture is called as Borjev syndrome. It can be as a result of instrumentation like endoscopy. Esophagitis, for example, infectious or pale or caustic can cause esophageal perforation, and esophageal ulcer can also cause it. The clinical presentation are chest and abdominal pain, systemic findings, for example, fever, subcutaneous emphysema in the neck. There is Hammond sign, crunching sound on chest auscultation, synchronous with the heartbeat, heard over the precordium, and produced due to the heart beating against the air-filled tissues. The diagnosis is done by the chest X-ray or CT. There will be a wide mediastinum, pneumomediastinum, pneumothorax, air around the paraspinal muscles, pleural effusion will be late, and there is often left-sided. On the CT scan, there will be esophageal wall thickening and mediastinal air fluid level. Water soluble contrast and esophagogram leak at the perforation site will also be seen in the water soluble contrast with esophagogram, and you must remember that there must be a water soluble contrast. We don't give barium in these cases because barium, if given in the Borjev syndrome, can leak into the mediastinum causing mediastinitis, and that is not what we want. Management is done by the antibiotics and supportive care for all patients. Surgical repair for a significant leakage with a systemic inflammatory response is also indicated. Then clinical presentation also include retrosternal pain. So that retrosternal pain is due to the contamination of the mediastinum with the gastric contents. The other point is management include making the patient nil paros, means the patient will not eat anything from mouth. We will give him IV or some other source of we will give him IV diet, but he will not consume anything with mouth. Administering intravenous proton pump inhibitors, broad spectrum antibiotics and nutrition, performing surgical drainage and debridement of the infected or necrotic area. Now let's move on to the secondary to endoscopy. So if the Borjev syndrome, if the esophageal perforation has occurred secondary to endoscopy, most common cause of esophageal rupture, especially if performed with other interventions like dilation or off stricture. It is life-threatening and requires emergent evaluation. Esophagogram with water-soluble contrast is preferred. There will be less inflammatory to tissue. So esophagogram with water-soluble contrast is preferred because it is less inflammatory to tissues. If non-diagnostic, we go for barium study that has higher sensitivity, but we prefer the water-soluble contrast. The treatment is done if perforation is confirmed. Primary course of esophagus and drainage of primary closure of esophagus and drainage of mediastinum urgently to prevent the development of mediastinitis. Some patients, including those with the minimal symptoms without signs of sepsis, those with a limited perforation, or those in the hospital with immediate thoracic backup, can be considered for non-operative management. Okay, so patients who have minimal symptoms without signs of sepsis, those who have a limited perforation, or those in a hospital with immediate thoracic surgery backup, they can be considered for the non-operative management. So here is the picture. This is a frontal chest X-ray, and you can see that there is widening of the mediastinum, like mediastinum is widened, I guess. No, not here. The widening of mediastinum can be appreciated here. Like this is the widening of mediastinum. So on the barium swallow, you can see that this is the spillage of the barium swallow in the esophagus. Now here you can see the description to that. So the very first thing that you need to see in this picture is spontaneous emphysema, subcutaneous emphysema that is present in these areas. Then this is pneumomediastinum. I'm sorry. This is not widening of mediastinum. This is pneumomediastinum. Now here you can see that this is the layer of pleura, and this is the mediastinal boundary, and between that you can see that there is a column of air. So this is pneumomediastinum that is depicted over here. I guess there will be widening as well because there is mediastinitis going on. Again, there will be pleural effusion as well. Okay. So in this picture you can see that this is esophageal lumen, and extravasated oral contrast is coming out in this direction and also over here. The next picture is about just give me a second. Yep. Now here you can see characteristic of gastroesophageal mural injury. The characteristic of gastroesophageal mural injury. Etiology. Okay, so the gastric esophageal mural injury can be divided into two categories. First one is the Mallory-Weiss syndrome, and the second one is the Borhe syndrome. So we'll talk about the Mallory-Weiss syndrome first. The etiology: upper gastrointestinal mucosal tear. In Mallory-Weiss syndrome, we find the upper GI mucosal tear. It is caused by forceful retching. Increased pressure or blunt abdominal trauma can also cause Mallory-Weiss syndrome. There will be submucosal arterial or venous plexus bleeding. The clinical presentation of Mallory-Weiss include vomiting, retching, hematemesis, epigastric pain. Risk factors include hiatal hernia and alcoholism. Laboratory imaging include endoscopy, gastroduodenoscopy will confirm the diagnosis. Longitudinal laceration and mucosal tear in the stomach or esophagus will be present. Treatment: for most tears they will heal spontaneously, like in 90% of the cases they will heal spontaneously. Endoscopic therapy can be done for continual bleeding. And how do we do the endoscopic therapy? We do the electrocoagulation or local injection of epinephrine. Now let's talk about Borhe syndrome. It is esophageal. The etiology is esophageal transmural tear caused by forceful retching and increased pressure. Esophageal air fluid leakage into the nearby areas, for example, pleura. The next thing is clinical presentation. So the clinical presentation of Borhe syndrome include vomiting, retching, chest and upper abdominal pain, odynophagia. Okay, so there is rapid progression to odynophagia, fever and dyspnea, and septic shock can ensue. Subcutaneous emphysema may be seen. Physical examination can be non-specific but usually shows fever, tachypnea, tachycardia and cyanosis. The laboratory imaging will show CT or contrast. Esophagography with gastrographin confirms the diagnosis, that is water-soluble contrast. Chest X-ray will show pneumomediastinum and pleural effusion, which are the late findings. The pleural fluid analysis will show exudative, low pH, very high amylase, more than 2500 international units per liter. So the UL usually left, what is that? With or without pneumothorax, mediastinal widening can be seen as the air fluid accumulate in the mediastinum. I don't know the meaning of UL. Upper limb, I think it is upper limb usually left. So, or upper lobe maybe, with or without pneumothorax. Pleural effusion. So I guess it is in the upper lobe, upper left lobe, with or without pneumothorax. Mediastinal widening can be seen as the air is filled and accumulates in the mediastinum, that will cause mediastinitis. The next thing is about the treatment. So treatment is done with a surgery for thoracic perforations and conservative measures for cervical perforations with antibiotics. They were saying that on pleural fluid analysis, very high amylase level are seen. Amylase due to the saliva in the esophageal content may also contain food particles in the pleura, in the pleural cavity. The next point is about the esophageal carcinoma. So the esophageal cancer, what are the subtypes? It can either be adenocarcinoma or squamous cell carcinoma. The adenocarcinoma is present in the distal esophagus and arises from the Barrett esophagus. Squamous cell carcinoma can be anywhere in the esophagus. What are the risk factors to that? Acid reflux, obesity which causes adenocarcinoma, smoking, alcohol, caustic injury and squamous cell. What is meant by squamous cell? Okay, no, caustic injury is more specific for the squamous cell carcinoma, right? Okay. Then symptoms are chest pain, weight loss and dysphagia for both kind of carcinomas. Diagnosis is done with endoscopy with biopsy, CT, PET, CT for staging. So here you can see that adenocarcinoma typically occurs in patients who have had GERD symptoms for more than 20 years. Adenocarcinoma is associated with smoking, high dietary calorie or fat intake, medications that promote GERD. Squamous cell carcinoma, dietary deficiency of beta carotene, vitamin B1, zinc, selenium, environmental viral infections, toxin producing fungi, hot food and beverages, pickled vegetables and food rich in N-nitroso compound, etc. So for definitive diagnosis of the esophageal carcinoma, especially start with this patient. Okay, so the patient was more than 55 years of age, with alarm symptoms like weight loss, gross or occult bleeding, and early satiety. For definitive diagnosis, especially start with this in patient. I guess the biopsy, endoscopy with the biopsy is the definitive diagnostic test of choice. Now, in the young and low risk patients with undetermined esophageal symptoms, may first go for the barium esophagogram. Treatment is surgery for definitive cure in the patient with a limited disease. But if the disease has been spread, or if it is malignant, then we can't do anything. Then this is just a palliative treatment. Now, what is upper GI bleeding? Upper GI bleeding can include hematemesis. It can cause dark tarry stool, which is melena, anemia, BUN cred ratio of more than 20. BUN blood urine nitrogen increases because of increased intestinal hemoglobin breakdown and increased urea absorption in the proximal renal tubule due to associated hypovolemia. So there are two things, that because of increased hemoglobin breakdown, increased urea is being produced in the GIT that is being absorbed, and secondly because whenever there is bleeding or hemorrhage, the blood flow towards the kidneys will be decreased, and the BUN absorption. So when there is going to be a decreased blood flow to the kidney, and that will lead to increased urea absorption in the proximal tubule because of hypovolemia. Blood urea nitrogen increases in upper GI bleeding and not the lower GI bleeding. You must remember this point, because just remember it, because the protein digestion occurs in the stomach, right? So the hemoglobin breakdown also occurs over there. So if there is lower GI bleeding, that breakdown will not take place. So BUN is not increased in the lower GI bleeding because the blood is absorbed as it passes through the small bowel. Higher the ratio, the more likely the bleeding is from the upper GI bleeding. The management is supportive management includes supplemental oxygen, bowel rest, and IV fluid infusion, while large bore catheters, IV proton pump inhibitor for acid suppression also reduce the rebleeding and need for transfusion and stabilize the clot in upper GI bleeding. Acid receptor blockers have not such benefit. The packed RBC transfusion will also be helpful because it increases the oxygen carrying capacity. Severe bleeding can result in hemodynamic instability and depressed level of consciousness. If vomiting is persistent in such cases, then airway needs to be secured. That is, we must perform intubation before other interventions are done. ABC, airway breathing circulation to be followed. It is controversial as to whether nasogastric tube placement decreases the risk of aspiration, but it certainly does provide the same level of airway protection as endotracheal intubation. Upper endoscopy should be done in an attempt to stop the patient's variceal hemorrhage, but this should be done after the patient is stabilized and intubated. Hematochezia, bright red or maroon colored stool, is most commonly due to the bleeding from the lower gastrointestinal tract, for example diverticulosis or hemorrhoids. However, rapid large volume bleeding from the upper GI source like peptic ulcer can lead to the hematochezia rather than the more classic melena, black and tarry stool typically associated with the upper GI bleed. Up to 15% of the cases of hematochezia are due to upper GI bleeding. In patients with a hematochezia and hemodynamic instability, it should be initially assumed that there is an upper GI source of bleeding. If there is no strong suggestion of a lower GI source, for example the passage of large clots, non recent diverticular bleed, if there is no suspicion for that, and there is a large hematochezia with hemodynamic instability, we must suspect the upper GI bleeding. This patient has orthostatic hypotension as well as risk factor for upper GI bleeding, for example ibuprofen use. So there is some patient, and there is a discussion of that discussion from that question stem. So the patient having orthostatic hypotension as well as risk factor for upper GI bleeding like ibuprofen, which is an NSAID, use. Therefore, following initial volume resuscitation and esophageal resuscitation, EGD, that is esophagogastroduodenoscopy, for identification and treatment, for example hemodynamic clipping of a suspected upper GI source, is most appropriate. If the endoscopic gastroduodenoscopy fails to identify a source, colonoscopy should be pursued. For the patients who remain hemodynamically unstable despite the initial volume resuscitation, interventional radiology procedures, for example angiography with embolization, are often the best alternative to endoscopic gastroduodenoscopy. Recommendation threshold for packed RBC transfusion. So when we give the packed RBCs, if the hemoglobin is less than 7, it is generally indicated to give the packed RBCs. In general, Stable patient without comorbid condition. Like if the patient is stable, there are no comorbid conditions, so we can give less. We can transfuse the blood if the hemoglobin is less than 7. If it is 7 to 8, cardiac surgery, oncology, patient in treatment and heart failure. So, with a hemoglobin of 7 to 8, the packed RBC transfusion is recommended for cardiac surgery, oncology patients in treatment and heart failure. If it is 8 to 10, then the hemoglobin is 8 to 10, then the recommendation is only for the symptomatic anemia, ongoing bleeding and hypovolemia, acute coronary syndrome and non-cardiac surgery. Higher threshold for this due to initial HB concentration not fully reflecting the blood loss. Also, hemoglobin concentration may drop significantly as the blood volume is replaced by the crystalloid and mobilization of interstitial fluids. Okay. The next thing is about hemoglobin that is more than 10. So, if hemoglobin is more than 10, then packed RBCs transfusion is not generally recommended. Recommendation for infusion of the fresh frozen plasma. It contains all the clotting factors and plasma proteins from 1 unit of blood. Indicated for severe coagulopathy, for example, liver disease or disseminated intravascular coagulation with active bleeding. Generally not indicated to correct the minimal abnormal INR that is less than 1.6. Recommendation for platelet transfusion. It is given for the platelet count of less than 10,000 per millimeter cube because increased risk of spontaneous hemorrhage. Given to the platelet count less than 50,000 per millimeter cube with active bleeding. Recommendation for whole blood transfusion. That is PRBC with plasma. What is PRBC? I don't know. In severe hemorrhage, for example, the massive trauma requiring massive transfusion to assist in volume expansion. Then the next topic is about the acute erosive gastritis. There will be severe hemorrhagic erosive lesions, etiology, exposure of gastric mucosa to the injurious agents, or substantial decrease in the blood flow. Aspirin causes decrease in the protective prostaglandin and direct mucosal injury. Alcohol use also causes direct mucosal injury, so aggravates the aspirin effect. Mucosal injury, that is decreased protective barrier, that is decreasing the bicarbonate and mucins, and decreased epithelium integrity, allow the acid and luminal substances like proteases and bile acids to penetrate to the lamina propria, further injury to the vasculature and subsequent hemorrhage that will result in the hematemesis and abdominal pain. So, I guess we should continue with the gastric carcinoma in the next session. Yeah, we'll continue with gastric carcinoma in the next session. Until then, Allah Hafiz, fi amanillah, and take care.